Welcome back to the channel. Today, we need to have a serious, deeply honest conversation about something hiding quietly inside your routine blood work right this very moment. A specific marker that can tell you whether you are heading toward a devastating stroke 5 years before it ever occurs, and yet almost no doctor over the age of 60 is routinely ordering the test to measure it. Over my years in preventive medicine, I have watched patients walk into emergency rooms with one side of their face drooping, unable to speak or move their limbs. In case after case, when we look back at their medical history, the warning signs were already sitting in their blood files years earlier. They had never been tested for it because the standard medical system simply does not look for it by default. I want to be completely transparent with you right from the start. I am Dr. David. I spend my days deep in the medical literature, reviewing complex peer-reviewed clinical trials that sit behind academic paywalls and dense scientific journals, translating them into practical guidance that ordinary adults can actually use to protect their long-term health. I am not your personal physician, and nothing we discuss today replaces the personalized advice of the doctor who knows your individual medical chart inside and out. But what I am going to share with you today is a series of critical findings that most traditional clinical appointments simply do not have the time to cover. In a standard 15-minute medical checkup, your doctor is racing against the clock, managing prescriptions, reviewing basic lab panels, and addressing acute complaints. They do not have the luxury of sitting down with you to walk through advanced genetic risk markers. Because that vital information rarely makes it into the typical examination room, millions of people continue daily habits unaware of underlying inherited vulnerabilities. This invisible marker is called lipoprotein a, frequently written as LPA. The primary reason you have probably never heard of it is not because it is rare. In fact, roughly 1 in 5 adults carries a dangerous, elevated level of it. That is about 20% of every waiting room you have ever sat in, 20% of your own family members, and 20% of the people walking past you at the grocery store. The reason it remains so unfamiliar is that the standard cholesterol panel your doctor orders every single year does not measure it, has never measured it, and will not measure it unless you specifically request it by name. To help you navigate this vital topic safely and effectively, we are going to break down 5 essential areas today. First, we will examine precisely what LPA is and why it raises stroke risk in a way that traditional diet and exercise barely touch, the very reality that catches people completely off guard. Second, we will provide the exact name of the lab test to ask for and the billing and diagnostic codes that get it approved, so you do not get turned away at the front desk. Third, we will explore the numerical thresholds that separate safe from dangerous levels and clarify what diagnostic laboratories often get wrong when reporting these results. Fourth, we will look at 3 distinct categories of people who absolutely must get this test, including one high-risk group that most cardiologists overlook entirely. And fifth, we will tackle the single most common mistake people make after receiving a high result, a critical error that wastes years of potential protective treatment and leaves good, careful patients vulnerable. Let me introduce you to someone named Eleanor. Eleanor is 68 years old and lives in the same brick house outside of Asheville, North Carolina, that she and her husband bought back in 1984. By every conventional standard, Eleanor did everything right. She walked 4 miles every single morning without fail, ate fish twice a week, and consumed almost no red meat. Her weight had not fluctuated by more than 5 pounds in 2 decades. Every single year, her physician ran a standard lipid panel, and every single year, the numbers came back reassuringly pristine. Her total cholesterol sat comfortably around 190. Her low-density lipoprotein, the so-called bad cholesterol, was a tidy 110. Her high-density lipoprotein, the protective kind, was a healthy 62, and her triglycerides remained well under 100. By every line on that laboratory report, Eleanor was the textbook patient you would put on a medical poster. Her doctor would glance at the sheet, nod approvingly, and tell her to keep doing exactly what she was doing. And from the standpoint of what that standard sheet could show, her doctor was entirely correct. Then came a Tuesday morning in March. Eleanor was rinsing a coffee cup at her kitchen sink when the ceramic cup suddenly slipped out of her right hand and shattered on the floor. She looked down in confusion, completely unable to understand why her fingers had abruptly stopped working. Within 90 seconds, the right side of her mouth went completely slack, and her husband immediately dialed 911. The blood clot was lodged directly in her left middle cerebral artery, the major vessel that feeds the language centers and the motor control regions for the right side of the body. That anatomical reality explains why her right hand failed first and her speech vanished second. Eleanor suffered a major ischemic stroke, a sudden blockage cutting off blood flow to the left hemisphere of her brain. She spent the next 4 months relearning fundamental life skills, such as how to button a shirt and how to say her own grandchildren's names. Every single minute that artery stayed blocked, approximately 1.9 million neurons died. That is the unforgiving arithmetic of a stroke. The brain does not wait. and it does not regrow what it loses the way a cut on your hand heals over. Here's the most critical fact. Nobody had ever measured the one marker that mattered most. Following her stroke, the hospital cardiologist ran an advanced diagnostic panel, and Eleanor's LPA level came back at a staggering 180 nanomoles per liter. The clinical threshold where cardiovascular risk begins to climb sharply is approximately 75 nanomoles per liter. Eleanor was sitting at more than double that threshold, and she had been carrying that exact elevated level her entire adult life. Why? Because LPA levels are determined almost entirely by the genetics you inherit at birth. Her morning walks did not lower it, her healthy fish dinners did not lower it, and her normal-looking annual cholesterol panels never showed it because LPA simply does not appear on a standard lipid profile. Large population studies, including the massive Copenhagen City Heart Study that followed tens of thousands of participants for decades, have demonstrated that individuals with the highest LPA levels carry up to 3 times the risk of adverse cardiovascular events compared to those at the bottom of the range. Crucially, that heightened risk persists even when traditional factors like LDL cholesterol, blood pressure, and smoking history are fully accounted for. In other words, Eleanor's underlying risk was stacked silently on top of her perfect laboratory numbers, completely invisible underneath them. The clot that stole 4 months of her life had been forecasting itself in her bloodstream since long before she retired, and the diagnostic test that would have caught it costs less than a tank of gasoline. I am sharing Eleanor's story not because her situation is rare, but because it is heartbreakingly typical. The patient most likely to be blindsided by a stroke is frequently not the one with alarming, out-of-control cholesterol numbers. That patient catches immediate medical attention, receives a statin prescription, and gets close follow-up care. Instead, the victim is often the individual whose standard laboratory numbers look immaculate, who therefore never receives a second look from their doctor, and who walks out of the clinic feeling completely reassured, only to return on an emergency stretcher later. To understand why this happens, let us examine the underlying biochemistry in clear, simple terms. Lipoprotein a is essentially a sticky, highly specialized cousin of ordinary LDL cholesterol. Picture regular LDL as a small, straightforward delivery truck transporting cholesterol molecules through your bloodstream. LPA is that exact same delivery truck, but with an extra, aggressive protein structure bolted onto its exterior, a specialized protein known as a polypoprotein EA. That extra bolted-on protein performs 2 distinct dangerous functions inside your vascular system. First, it makes the particle far more sticky and chemically aggressive, dramatically increasing its likelihood of burrowing deep into the wall of an artery to initiate plaque formation. Furthermore, LPA carries oxidized phospholipids, the single most inflammatory cargo circulating in your bloodstream. These molecules act like a persistent chemical alarm bell that summons immune cells directly into the artery wall. Those immune cells gorge themselves on the trapped cholesterol, transforming into foam cells that form the soft, unstable, rupture-prone core of a dangerous arterial plaque. Second, and this is the vital detail that most people have never heard, that bolted-on polypoprotein A molecule closely resembles a natural substance in your body called plasminogen. Plasminogen is the raw material your body converts into plasmin, which is the specialized enzyme designed to chew through blood clots and dissolve them before they cause damage. Because the protein on LPA mimics plasminogen so closely, it actively competes with it and crowds it out, jamming your body's natural cellular machinery. Therefore, LPA does not just help build dangerous vascular blockages, it simultaneously disables your body's ability to break down a clot once it forms. It represents a devastating 2-front assault on your brain's blood supply. It loads the gun and then actively jams the safety mechanism. Because the quantity of LPA your liver synthesizes is dictated by a single gene known as the LPA gene, and specifically by a structural feature within that gene called the Kringle repeat sequence. The more of these repeat sequences you inherit from your parents, the larger and slower the circulating particle tends to be, which generally results in a lower, safer level in your blood. Conversely, inheriting fewer repeats produces smaller, denser particles, resulting in dramatically higher and more dangerous concentration levels. You inherit 1 copy of this gene from each parent, and your unique pattern is permanently fixed by early childhood. According to extensive research published in premier journals like The Lancet and Circulation, your LPA level remains remarkably stable across your entire lifespan, varying far less than your standard LDL cholesterol, your blood pressure, or your body weight ever will. A person measured at age 25 and tested again at age 65 will almost always land within a very narrow numerical band both times. This fundamental biological reality explains why conventional lifestyle advice fails completely when applied to this specific marker. Eating a pristine diet, losing excess body weight, and engaging in vigorous daily exercise can meaningfully improve your standard LDL cholesterol, reduce your triglycerides, and lower your blood pressure. Yet those same healthy habits barely budge your LPA level. Even high-dose statin medications, which are exceptionally powerful for lowering standard LDL cholesterol, can paradoxically nudge LPA concentrations upward in certain individuals. For many patients, that is the hardest medical truth to accept. You can be the absolute picture of physical fitness at your local gym, run marathons, maintain the body fat percentage of a professional athlete, and still carry an inherited genetic level that doubles or triples your stroke risk. No amount of clean living will lower the marker itself, because lifestyle cannot rewrite the genetic instructions encoded in your liver. This brings us directly to the structural reason why your traditional doctor has never ordered this test for you. The standard lipid panel was designed decades ago in an era when the pathological relationship between LPA and vascular disease was not yet firmly established in clinical science, and it was never updated to include LPA as a routine screening component. Insurance reimbursement structures heavily reinforced this omission because, historically, there were no approved pharmaceutical agents specifically designed to lower the marker. The prevailing medical logic was straightforward. Why test patients for a genetic abnormality if you cannot offer them a targeted treatment? That clinical logic is now entirely outdated, yet it remains the primary reason the test sits outside routine physical exams. It is not ordered because it does not appear on standard laboratory order forms, and it remains absent from those forms due to legacy decisions made long before modern cardiovascular genetics advanced. Medicine suffers from a notoriously long lag time between what emerging scientific evidence proves and what standard clinical order sets reflect, and LPA has been trapped in that administrative gap for the better part of a generation. European health authorities moved much faster, with the European Atherosclerosis Society recommending at least once-in-a-lifetime testing years ago, while much of North American medical practice still requires patients to specifically request the assay by name. This structural oversight explains why Eleanor's pristine annual panels missed the danger entirely. Her standard LDL reading of 110 was genuinely fine. Her physician was not negligent, but was simply reading the only instruments installed on the medical dashboard. LPA was a critical secondary gauge that was never wired into the system, allowing the engine to overheat silently in the background. Let us expand our view, because Eleanor is just one face of a much larger demographic pattern, and you may recognize your own family history in one of the following three profiles. Consider Marcus. Marcus is 62 years old and a retired high school football coach living in Ohio. Marcus manages slightly elevated blood pressure with a single daily medication, but he carries a family medical history that he never thought much about. His father tragically died of a stroke at age 64. His older brother suffered a heart attack at 58, and an aunt on his father's side required emergency bypass surgery in her early 60s. Marcus always assumed this cluster of cardiovascular events was simply bad luck, the kind of generational misfortune families casually chalk up to bad weather or generic family constitution. When Marcus finally requested an LPA test after a niece who works as a nurse urged him to look into it, his results came back at a concerning 140. Marcus is the classic case illustrating hidden genetic inheritance. That tragic string of early strokes and heart attacks in his family tree was not random statistical noise. It was almost certainly the exact same elevated genetic marker passing silently down through the generations, remaining invisible simply because no one in the lineage had ever been tested. Remember the underlying genetics. If Marcus carries a high-risk version of the LPA gene, each of his children has roughly a 50% chance of inheriting that exact same genetic variant, and so did each of his siblings. The family tragedy that looked like an unavoidable curse is actually a single inherited genetic trait that is fully traceable, easily testable, and now finally visible. If you have a parent, sibling, or child who experienced a stroke or heart attack before the age of 65, Marcus represents your family history, and you need to hear that message clearly. That early age of onset is one of the strongest clinical clues that an inherited marker is at work, completely distinct from the slow accumulation of ordinary lifestyle risk that typically manifests in later decades. Next, consider Joyce. Joyce is 71 years old, lives in an active retirement community in Florida, and has been told by everyone her entire life that she is the absolute picture of robust health. She is lean, highly active, and has followed a strict vegetarian diet for over 30 years. She participates in water aerobics 3 mornings a week and has never smoked a cigarette in her life. Joyce represents perhaps the most dangerous and overlooked category of all, because Joyce, her friends, and her doctors all assumed she was the last person on earth who needed to worry about cardiovascular disease. Her routine cholesterol panel always looked pristine, yet when she finally requested an LPA assay, her result came back at 95. Not as stratospheric as Eleanor's, but well past the safe threshold where vascular risk climbs sharply. Joyce serves as a vital reminder that this specific marker does not care how lean you look, how clean your diet is, or how many laps you swim. Trifpicht, the vegetarian lifestyle that kept her standard LDL cholesterol admirably low, did absolutely nothing to alter the genetic particle that mattered most, because LPA is not a dietary cholesterol issue. It is a genetic manufacturing defect originating in the liver. Patients like Joyce are routinely overlooked precisely because they appear far too healthy to warrant specialized screening, and that clinical oversight is not harmless. It is the primary reason the diagnosis so often arrives in the form of a catastrophic medical event rather than an advance warning. Finally, consider Raymond. Raymond is 65 years old, a Black American man and a retired postal worker living in Chicago. Raymond is important to highlight for a specific medical reason that even many practicing cardiologists fail to weigh heavily enough. Comprehensive epidemiological data summarized by the American Heart Association indicates that elevated LPA is statistically more prevalent and tends to run significantly higher in individuals of African ancestry. Population studies suggest that approximately 30 to 35% of Black adults carry elevated concentrations of this marker, a notably higher share than is typically found in white populations. Yet, this exact demographic group is frequently the least likely to be screened because routine LPA testing is not standard practice for anyone, meaning individuals at the highest statistical risk fall through the exact same systemic cracks as everyone else, only wider. There is a bitter compounding injustice operating here. Stroke already strikes Black Americans earlier and more frequently on average, and one of the quiet, unmeasured contributors sitting underneath that distressing public health statistic may be an inherited genetic marker that almost no one is ordering for the very populations most likely to carry it. Raymond represents the overlooked category. If you or your loved ones share this background, testing moves rapidly from an optional inquiry to an essential health priority. When you step back and look at the entire picture, patients with normal standard cholesterol panels, dangerous levels left unmeasured, and silent risks ignored until an emergency forces the issue, the magnitude of the problem becomes clear. The risk is remarkably common, entirely silent during its development, strictly inherited, and currently sitting inside a blood test that almost no routine clinic is running. To ensure you can take proactive control of your health this very week, here is the exact step-by-step action plan to follow. Step number 1. Request the diagnostic test by its exact correct medical name. When you walk into your clinic or call your doctor's office, state clearly, I would like to request a lipoprotein (a) blood test, specifically measuring LPA. Articulate it clearly because administrative staff may not recognize casual shorthand the way they instantly recognize a standard cholesterol check. Some medical electronic health record systems list the assay simply as LPA, with the letter A in parentheses, which is the abbreviation to look for on paperwork. It is a straightforward blood draw utilizing the exact same needle and collection tubes as your regular lab work, and it can frequently be drawn during the exact same clinical visit. Unlike standard lipid panels, you do not need to fast overnight for an LPA test, which sets it apart and allows you to have the blood drawn at any time of day. Most importantly, because your genetic level remains exceptionally stable across your lifetime, this is generally a once-in-a-lifetime test. Think about that powerful advantage for a moment. The vast majority of diagnostic tests your doctor runs must be repeated year after year because fluctuating lifestyle factors cause numbers to drift. An LPA test is performed once, and it provides you with permanent, true insight regarding your genetic risk profile for every decade that follows. Step number 2. Ensure the lab order is properly coded for insurance coverage. The diagnostic code your doctor enters into the electronic order set must correspond directly to the measurement of lipoprotein (a), utilizing the standard current procedural terminology or CPT laboratory assay codes. You do not need to memorize complex billing digits. What matters is communicating the correct clinical justification to your provider. Say this clearly to your physician. I have a documented family history of premature cardiovascular disease and stroke, and I want to assess my personal vascular risk beyond standard cholesterol panels. That clinical reasoning provides the necessary medical necessity required to justify the order and support insurance reimbursement, because coverage decisions hinge on documented familial risk factors. If administrative staff at the front desk hesitate, mentioning that family history of premature vascular events is usually all it takes to secure approval. Furthermore, even if insurance coverage encounters a temporary hurdle, the out-of-pocket cash price for the assay at major commercial laboratories has become quite modest, often comparable to a routine copay, ensuring that financial cost never becomes an insurmountable barrier to obtaining life-saving knowledge. Step number 3. Learn how to interpret your numerical results correctly, because the reporting laboratories themselves frequently cause widespread confusion here. LPA results are reported using two completely different units of measurement, depending on the specific laboratory handling the sample. Some facilities report values in milligrams per deciliter, which measures the total physical mass of the circulating particles. Other facilities report values in nanomoles per liter, which measures the actual numerical count of individual particles. The crucial clinical reality is that the numerical cutoffs differ significantly between the two units. The nanomoles per liter measurement is generally regarded by specialists as the more accurate metric because it counts the actual number of particles directly rather than estimating their total weight. A distinction that matters immensely because individual particle sizes vary widely from person to person. As a general guide drawn from published clinical thresholds, an LPA level exceeding approximately 50 milligrams per deciliter, or above roughly 125 nanomoles per liter, is considered clinically elevated, a meaningful signal demanding proactive management. High with overall risk climbing higher as the numbers increase. The single most important rule is to ask your laboratory which specific unit of measurement was used for your report. A numerical value that looks alarming in one unit can be completely normal in the other, and conversely, a number that appears deceptively fine can actually be dangerous depending on the scale. Never let confusing units fool you. Always ask your physician to interpret the specific result within the context of your overall health profile. Step number 4. If your LPA result returns elevated, focus your energy on driving every other modifiable risk factor under aggressive, airtight control. This is where you actually win the battle for your vascular health. While you cannot currently lower your baseline LPA level directly with standard lifestyle interventions or common medications, a high LPA functions as a powerful multiplier on every other risk factor you carry. Think of it as turning up the master volume knob on every underlying vulnerability in your system. The way you protect your brain and your heart is by driving all other cardiovascular risk factors down as aggressively as modern medicine allows. That means partnering closely with your physician to get your standard LDL cholesterol as low as clinical evidence supports. For someone carrying an elevated LPA risk, that often means targeting LDL levels well below standard population recommendations, sometimes dropping below 70 milligrams per deciliter or even lower, because every single particle of LDL you remove from circulation takes away a portion of the raw fuel that feeds plaque accumulation. It means keeping your blood pressure tightly regulated with medication and lifestyle adjustments, because chronic pressure stress is what ultimately ruptures the vulnerable plaques that LPA helps construct. It means strictly avoiding tobacco use in any form, since smoking aggressively damages the delicate endothelial lining of your blood vessels and accelerates every destructive inflammatory cascade. Finally, it means meticulously managing your blood sugar, because insulin resistance and diabetes compound every form of vascular injury on this list. Discovering a high genetic marker does not mean you are helpless. It simply means your remaining metabolic dashboard matters more than ever, and bringing those other numbers down dramatically reduces your cumulative risk, even while your baseline LPA level remains unchanged. This brings us directly to the critical trap that many well-meaning patients fall into, the single biggest mistake I promised to address at the start of our discussion. Patients receive a high LPA result, hear their doctor explain that diet and exercise will not lower the marker directly, and mistakenly conclude that nothing can be done. Consequently, they throw their hands up, abandon hope, and lose precious years of protective management that they could have been building the entire time. Remember this core principle. Your genetic marker is fixed, but your overall vascular risk surrounding that marker is entirely manageable. Do not surrender your health to despair just because a number cannot be instantly rewritten. Step number 5. Share your test results with your blood relatives immediately. Because LPA is an inherited genetic trait, discovering an elevated level in yourself serves as an urgent flashing warning sign for your children, your siblings, and your parents if they are still living. Recall the foundational genetics we discussed earlier. With each first-degree relative carrying roughly a 50% statistical chance of inheriting the identical high-risk gene variant, a single positive test result in your chart is essentially a detailed map of cardiovascular risk spanning your entire family tree. Performing one simple test in your own life can prompt targeted screening across an entire household, catching the next Eleanor long before her coffee cup ever slips and hits the kitchen floor. It also delivers the highest clinical payoff per dollar spent in all of cardiology, because a single blood draw triggers a cascade of awareness in the exact individuals most likely to benefit. Now, let us examine an exciting frontier that goes far beyond standard medical advice, an area that even a recent American Heart Association scientific statement subtly underplayed. For years, the primary justification medical textbooks gave for ignoring routine LPA screening was the complete absence of targeted pharmacological treatments. That justification is evaporating rapidly. We are currently witnessing a massive revolution in cardiovascular therapeutics. There are now revolutionary medications undergoing advanced phase 3 clinical trials specifically designed to lower lipoprotein a directly and dramatically. One major class of experimental drugs utilizes specialized antisense oligonucleotides, while another class employs small interfering RNA technology. Both of these advanced therapeutic approaches work upstream at the cellular level, instructing the liver to synthesize far less of the apolipoprotein A protein in the first place, rather than attempting to clean up the damaging particles after they are already circulating in the bloodstream. Early clinical trial results have been nothing short of staggering, with some of these investigational agents demonstrating reductions in circulating LPA levels by 80% or more, the kind of massive downward shift that traditional diet and exercise could never approach. While these breakthrough therapies are not yet universally approved for general pharmacy dispensing, and I am certainly not telling you to expect a prescription on your next routine visit, there's a powerful practical move available to you right now. If your laboratory test returns significantly elevated, ask your physician specifically about your eligibility to participate in ongoing clinical trials, evaluating novel LPA-lowering therapies in your region. Pharmaceutical research centers are actively recruiting individuals with elevated LPA levels for these exact studies. Participating in a clinical trial can grant you early access to cutting-edge medical treatments years before they officially reach commercial pharmacies, all while receiving exceptionally close monitoring from specialized cardiologists who will watch your vascular health more carefully than almost any standard outpatient practice could ever manage. This specialized option does not apply if your normal screening results are pristine, and it certainly does not replace the necessity of controlling your immediate blood pressure and cholesterol today. But for the individual sitting with an LPA reading of 180, just like Eleanor, knowing that targeted, disease-altering treatments are rapidly approaching on the horizon, and realizing that an active clinical trial may be welcoming patients right now, completely transforms the emotional landscape from a feeling of helpless resignation to one of empowered, proactive defense. Talk openly with your doctor about whether exploring clinical research aligns with your personal medical journey. If today's discussion has shed bright light on a critical health topic that your past medical appointments never mentioned, the single most useful thing you can do right now is to hit the like button below and subscribe to the channel. Every new subscriber signals our automated systems to push this vital educational content to one more adult over the age of 50 who currently has a pristine-looking standard cholesterol panel and zero idea that a second about critical diagnostic gauge was never installed on their medical dashboard. Make sure you stay tuned for our next session, where we break down the two distinct blood pressure numbers and reveal which one actually predicts stroke risk, because the number most people watch closely is not always the one that matters most for long-term brain health. Above all, if you take only one decisive action away from everything we have covered today, let it be this. If you have a parent, a sibling, a spouse, or a close friend over the age of 60 who has always received normal cholesterol test results and therefore assumes they are completely in the clear, send them this video today. They may be carrying an inherited genetic marker that no one has ever measured in their lifetime, and a single diagnostic test requested explicitly by name could provide them with the 5 years of advanced warning that Eleanor never received. Share this message with the person who popped into your mind while we were talking. Take wonderful care of your cardiovascular health, and I look forward to seeing you in our next educational session.